Good evening, everybody. I'm Susan Clinton here with my co-host Carolyn Van Dicken, and this is the Genius Project. We're in project number 9. This is part B, where the audience gets to ask Dr. Sinead Dufour questions. And let's have a discussion about the challenge and the opportunities of lifestyle as medicine and how Dr. Dufour made the switch over from just a regular physical therapy practice into incorporating lifestyle as medicine.
Awesome. Well, thank you again, Sinead, so much for joining us and for sharing your journey with us last time. Do you want to just maybe do a couple minute recap on kind of where your journey through physiotherapy profession has taken you? And then maybe we'll just open up the floor for questions from our participants, which we're glad to have Nicole and Janice and Marion with us tonight.
Yes, absolutely. And again, thank you for having me. So I'm Sinead Dufour. After I graduated from physio from McMaster University, I went into private practice, much like many of my colleagues who I graduated with. And through that experience, I actually was feeling that there almost wasn't enough of a sort of, I guess you could say, holistic approach to health. It appeared to me that there was lots of gaps. And it was right around the time actually where the province of Ontario, where I am, was actually reorganizing primary health care and really kind of reorganizing it in a way theoretically to really incorporate pillars of healthy living and lifestyle, and not necessarily having every issue funnel through a doctor and really trying to see the right person at the right time to get the right care. And this really resonated with me. So that actually landed me back to do doctoral work. And that, I guess, is really where I think the seeds were really planted, that we have to be kind of looking at this from a bigger perspective. Certainly, I saw the scientific data was really substantiating that care providers need to be doing this for better health outcomes. And that has really just stayed with me. So even through my journey, as I've now kind of morphed into women's health and pelvic health, I still very much practice in that kind of area, from this lens of looking at the pillars of health and looking at this, I guess you could say, more kind of holistic approach.
Amazing. I'm just going to open up the floor first. I know I have some questions for Sinead, but of course I always do. And I had an opportunity a few weeks ago to ask the question. So does anyone here have any questions for Sinead around what does that look like, or what are the challenges that we face in our own practice or the opportunities?
I'll start off, actually, if that's all right. So unfortunately, I didn't watch 9A. I'll have to admit, I didn't realize there was a 9A and a 9B. So I apologize if this is something you've already spoke to last time, but
it's all good.
I run into problems in that I'm really trying to adopt, my whole idea too is this, pillars of health and well-being, and in terms of, lifestyle, mindset, and connectivity, and all that sort of stuff. And I struggle with my boundaries in terms of my professional role as a physiotherapist. And I've heard different things, but you have to be very mindful or careful as to what you suggest to clients, because it's out of your scope as a physiotherapist. And I struggle because partly I see it as it should be in the scope of physiotherapy, because say, for example, someone's constipated and it's because of their dietary habits. Not that I'm going to espouse a specific diet, but there's certainly recommendations I think that I can make based on a lot of courses that I've taken and research, that I feel that I can make those calls, but I'm sort of told that no, that I shouldn't be doing that. But then their constipation is causing their issues that they're seeing me for. So how do I deal with that or get around that? Or is there anything that I can do about that?
Yeah, so this is a great question, actually. This is a question that comes up a lot. And I think this is actually one of, not the only, but one of the big stumbling blocks for our physio profession anyway, and probably actually for other professions. So how I would answer that actually is more, it comes down to really actually the way in which we do our care. And that's what will kind of mitigate that issue. So let me just explain it further. So physiotherapists and other providers, but physios are very much trained to do exactly what you said, right? Look at kind of patterns, see what's happening with their clients, and then give recommendations. Be very prescriptive, do treatment, do a treatment approach, do recommendations. And you're quite right that when we come into things like diet, especially, I would say less so around kind of maybe sleep or stress system resilience, but especially with nutrition and diet, it becomes contentious because there's dietitians and there's nutritionists, and then where do we step over that line, right? So it comes up a lot. But actually, when we look at the whole purpose of trying to engage someone to understand how their way of being is ultimately influencing their health status, right? And for them to kind of understand that, but then actually to be able to make some behavior change in a direction that will maybe be more constructive for them, we actually have to take off our prescriptive way of doing things. And this is where we have to shift into our coaching role. So this is where it's really helpful to have those skills where now we're kind of motivationally interviewing, we're coaching, we draw on our expertise so that we can have the individual in front of us have more conviction about the issue. But at the end of the day, if we truly are following more of that coaching approach, which is actually what I suggest when we're doing anything to do with lifestyle interventions, for the very reason that you just said, it never becomes an issue of our stepping out of our scope, because all we are doing is engaging in dialogue around health creation and health promotion, which is clearly in our scope. But what's not in our scope is to make recommendations and prescriptions. But in a health coaching role, you don't do that. You engage in a dialogue, and at the end, the individual comes up with their own action plan. So they will kind of reflect and say, okay, so yeah, now what, based on what you're saying, I think what I'm going to do for myself is eat more fiber, or they come up with their own plan, right? And this is the very way we mitigate that issue, because that is sort of a real issue, especially when it comes to nutrition. But if we aren't engaging in that knowledge through a prescriptive means, and we're kind of engaging with it through a coaching means, that the individual in front of us, they're determining what they're going to do. Just like the individual in front of us might kind of walk into a pharmacy and buy some Advil. Like, we can't tell them and prescribe them to do that, but we can engage in a conversation about something and they come up with their own action plan and they do it. So when it comes to lifestyle, that is really, I think, if we can get physios to kind of have a skill set where they can be chameleons. It's not like we totally get rid of our other skill set where we are truly doing some prescription. That definitely has a place. But we need to almost be able to flip back and forth to when it comes to these aspects. It's really about engaging, using some of those cognitive skills, and then they come up with their own action plan. That's kind of how I would answer that first. Do you have like a follow-up question, or did that help?
Yeah, kind of. Yeah, I guess I still, sorry, that was very vague on my part. Because I think I try to do that anyway. Like, I try to sort of give them general ideas or certain things, but then they'll say, well, how can I do that? Or what can I do? Or what do you suggest? So then it's kind of like, okay, where do I go?
Right. So how I would handle that is I would say, well, the data says this, right? Like, I'm a physiotherapist, but the data would show this. Certainly there's, a package of data that would suggest, let's say we use sleep for an example, that, the more hours you're sleeping before midnight has XYZ effect on your biology.
Right.
And we certainly know that doing XYZ has X effect. And given that your symptoms are XYZ, I mean, it's very plausible that there's some opportunity to modulate your biology if there was like a change in your operating rhythm here. But again, like, you're passing it over to them.
Right. Yeah.
Not telling them to do anything. So I tend to really, try as much as I can. Honestly, one of the strategies that I use is I try to link it back to explaining the biology of it, because that's where I see my role as an expert in human physiology. I'm a physiotherapist, right? So I can take these things, and that's how I can best leverage my role as a knowledge translator, which will hopefully give them enough conviction to think, oh, okay, I think that's important. What I often find is, when they circle back with me and I say, so what did you come up with in terms of what you were going to do to make a change after? And they kind of let me know. And then that sometimes is a nice point to then work a little bit more on the confidence things, because they can say, yeah, actually, what I really took away was X, Y, Z. And so I went and tried to put it into practice. But now I'm realizing that my stumbling block around sleep, and one of the reasons why I'm not getting to bed at 1 a.m, actually has to do with this other thing that I didn't even realize that was a thing. So then we can get into trying to problem solve around that barrier. And of course, these are all motivational interviewing skills and health coaching skills. But that's sort of how I tend to target it. So I'm still never prescribing. So it never can come back to me as an issue, if that makes sense. And I try to ground it as much as possible in what very clearly is the bread and butter of a physio, which human physiology is. No one can kind of deny that. So I think when I'm coming back to it, and that's often a place where people generally do understand, like they get it that they got to eat healthier. They get it that the broccoli's healthier than, the bag of chips. Like people get that. But what they often don't get is biologically how that's impacting their system. And we know from, our pain science information that kind of explaining things in physiologic terms from that perspective seems to resonate well with people, right? And so I sort of, I guess, apply that basket of research onto this piece. And that's how I kind of reground it to my role as a physio. So that's what I do. I don't know if maybe that would be a helpful approach.
Yeah, no, thank you.
I wonder, as I'm listening to this, I had an interesting conversation. I have a social worker who actually does some psychosocial coaching with me. I bring sort of some of my difficult, like a supportive role for me. And so we were chatting last week, and we were talking about the barriers that physios have for adopting a broader psychosocial perspective and sort of delving into some of those issues with patients. And her comment was, I wonder if physiotherapists are uncomfortable doing that, working in that role because they still see themselves as fixers and not facilitators. And I really kind of sat back and went, I think primarily for physios, our role has been to be fixers, right? Biomechanically. And so again, it's when I listen to Sinead talk about really, explaining the data and knowledge translation, I think one of our challenges is that even in the courses that I teach and I've been involved in teaching, it's almost like we're very strategy based still. And I wonder if we're missing the grounding of physiology and really understanding that piece so that we can use that very comfortably. And I'll go back to pain science even. One of the things that I've been sort of looking at across Canada for sure, and we just did a survey on, was why are Canadian physiotherapists so hesitant to take pain education courses? Like, what is it about that piece? I would say every course that I teach, when I ask people how many people have actually done a pain science course, about 10 to 20% of physios who are taking a course on how to apply biopsychosocial principles, but they haven't even done a pain science course yet. So how can they translate knowledge when they don't have those basic physiological principles? And I think that's an underlying problem that we have. I don't know, Nick, what you think, because I know you've been in this kind of world for.
Yeah. You know what? I think that's probably a fair point. I think in fairness, when I look back at just some of my experiences, one of the other things I've done is I taught pathophysiology in the nurse practitioner program, which is a consortium program across the province of Ontario for 5 years. And I remember the first year I was hired in to do it, I was actually really intimidated because I wasn't sure, I really knew the pathophysiology as well as I would need to not only teach, physiotherapists who are my profession, but like this other professional group. And perhaps maybe it's that I had that knowledge scaffolded over and over and over because I was teaching it. But I have to say it was also through that experience that it was very clear to me that even the way we were teaching pathophysiology to nurse practitioners, we really actually weren't teaching sort of how systems physiologically work and then what really modulates those systems. It was really interesting. We would still kind of get to a place of, suspected etiologies, a bit of a glossing over of pathophysiology, which was never really a comprehensive understanding of the physiology and of the factors that mitigate it, and then sort of symptoms, and then trying to match symptoms with the medication, right? So even that was very eye-opening to me, I think. And that really actually led me down the path to get training in functional medicine. And I think through that training, I really learned a lot about the basics of physiological systems. And in fairness, probably that's why I have so much confidence as a practitioner engaging this way, because I can very easily talk about these things in a coaching style. But it probably is because I have some of that knowledge. So I think that's a good point, Carolyn. I think that probably is another gap, maybe. Mm-hmm. Yeah, that's a good point.
It's, just hearing you speak about that, it just reminds me of an interaction I had just a couple of weeks ago of, it was with a client who was postpartum, and there was some issues around some bleeding, and was it a period? What was going on? Was there some retained placenta? So there was all this sort of back and forth. So we were talking about this, and then I posted a question to a Facebook group, like a private Facebook group, sort of outlined this. And I sort of said, we talked about potentially, just how hormones are playing a role in this, and that, she's only 5 months postpartum, and there's dysregulation, and just I talked about sleep, and we talked about a bunch of different things that could be affecting why she's having this different pattern of bleeding that she was going on. And I was putting it out there to just ask some other suggestions. And one of the responses was like, oh, you have to tread very carefully when you start talking about hormones, because that's not within your scope of practice. And I was sort of thinking, I didn't really see that as not being part of what I could do, because I was, like you said, I was imparting knowledge. Mm-hmm. And it's physiologically, I mean, I'm not making stuff up, and it's like, she needs to understand why this might be happening. And it's because of all these different reasons. And it wasn't, so I was a little perplexed by that. And I thought, oh, what is that really not within my scope to talk about how your hormones may not be, like, it could be a hormonal imbalance that's going on. And anyway.
Yeah. So, I mean, and I think there's another reason why I think then it makes physios like yourself, for example, sort of almost want to back off the direction that you're going, because you think, oh, but I thought it was important. I would agree with you that I think that's physiology. Endocrinology is embedded with neurology and immunology. And again, anyone who's taken an updated pain science course, like Butler and Mosley have totally reorganized their course to really talk about neuroendocrine immunology and all of these pieces, right? So I would argue, hands down, that is your role. Mm-hmm. In terms of an awareness raising perspective, a discussion, maybe saying, yeah, these are some things, that could potentially be going on, might be a great thing to circle back with your doctor on, but it's not outside of your scope to talk about that. I mean, even if we think about, and if I reflect on the curriculum at McMaster University, because I'm a professor there, I mean, we teach the students with every different problem that they do, because of course it's problem-based learning. They have to learn about the mechanisms of action of the medications. They have to learn about exactly what is done in different surgeries based on the paper problem. They're not surgeons, they're not, but it's because understanding the mechanisms and the context and the influence, and they need to be able to discuss this. So if we're allowed to discuss medications, we're not prescribing them, we're not pharmacists, why wouldn't we be able to discuss normal hormone physiology? So I think that is some of our colleagues' interpretation that actually isn't correct, but that might be another thing keeping us stuck.
Mhm.
Right. And I think when we look at the whole, like, just take the idea of endocrinology, it doesn't just affect bleeding and menstrual cycles. It affects muscles, bones, joints, ligaments, and nerves. And that is what physios do. How can we be prescriptive if we're not considering the endocrine physiology? And I tend to kind of agree with that, but it is unfortunate when people say tread carefully, because it's like, that's, and especially in a place where it's like a written back and forth thing, it can become, misunderstood in many ways, on both sides. And, I applaud you for being here and asking those questions, because I think the more we dialogue about it,
Mhm.
the better it is. And so you don't have to tell, you're not going to tell her, okay, I want you to call your doctor and I want you to have these 4 tests done and da da da, just like Sinead said, circle back to the physician, maybe have a conversation about checking out your hormone levels. In the meantime, here's what else we know that can influence
Yeah.
and help with this situation. And whether, and you don't even have to know how all the data behind it, but you can say, one thing we do know, if we can find one thing that you can do that can consistently change some of this soup that you're in, that could be the trail to start making this a little bit better for yourself. So then they can kind of choose, as she was talking about with coaching, like, do you want to tackle a little bit around your sleep? Do you want to tackle a little bit around exercise balance? You're exercising Mach 5 with your hair on fire, or you're not exercising at all. So we can keep it in our realm in many different ways, but we know that sleep affects performance. And whether you're an athlete or you're just walking across the street, if you're tired, we know that you're not as aware of your environment,
Mhm.
and things like that. And it affects how you feel, it affects how you eat. So I think I love this conversation. Thank you, Nicole, for bringing it up, because I think it's really exactly relevant to what we're talking about tonight.
Well, and at the end of my day today, I did 2 new assessments today. And, one of the things that I see our role in is to actually help be a dot connector, right?
Mm.
And so if you don't understand the physiology of different systems and how they all work together, I had this today who had like a 5-year history of significant dyspareunia, had urinary retention, was told at 50 she needs to start self-catheterizing, got to see a really specialist tertiary clinic for a pessary, which she couldn't tolerate. And, it sort of all came back to no one's kind of looked at, sort of the whole story and what's going on. And she had a lot of tension. And so it started 10 years ago. And I just said to her very simply, what happened 10 years ago when this all started? And she just stopped and looked at me and said, my daughter was sexually abused
Mm.
at the age of 14. I've never put that together, but that's when all this started. And again, it's the dot connecting that and then we can help her understand the physiology and how that all fits together.
Mhm.
My last 2 assessments, their last words were to me were 2 things. That was amazing. I have so much hope now that I understand the big picture. And thank you for taking a whole person approach.
Yeah.
Was both of their parting words. And yet we are really afraid as physiotherapists to kind of start to make these connections. But all we're doing is connecting dots. My next question to her is, have you worked on kind of resolution of, and done some counseling around that piece? And she had, but she was still left with this sort of physiological fallout that happened as a result, right? So I'm not trying to be a counselor, I'm trying to be a dot connector. And we understand the system and can understand the system really well. And probably from a pain perspective, better than most healthcare professionals right now, at least. And if we can't help patients put those stories together, who is going to? Because she was at her wit's end, having seen really high level specialists and doing, many different things, that at 50, she was going to get better. And she absolutely is, right?
Yeah, absolutely. And I would agree that I see that as a big part of my role and how I mostly helpful for people. Certainly that is a piece that is emphasized in, the functional medicine training as well. But I don't think you have to have that training to kind of get it. I think you're right. If we we are not confident, I think that we don't sort of have anything to offer people. I think that's when too we'll back away. Certainly that is the feedback I will get from the family doctors that I teach at McMaster. And they can be rather forthcoming about it and to say, you know, this workshop on pelvic health, because I run a pelvic health workshop with them, was so helpful. To be honest, I actually haven't even gone there because I don't know how to assess it. I don't have any options for people other than surgery or referring them on to a specialist. So I don't even want to go there, right? And I think sometimes with other aspects of care, physios might be in the same boat. They just might feel like they don't have certain skills in a place, so they don't even want to open that door.
Excellent. Janice, do you have any comments or questions or thoughts for Sinead?
Thanks, Carolyn. Actually, I'm very, very new to this area of practice. Although I am a very seasoned clinician, my strengths comes from working with children and youth. And so looking at some of the issues that they face prior to entering adolescence or when they're in adolescence, and then transitioning into adult care. So I'm drawn to this on two levels, on a very much a professional level, looking at where our profession has, how it's grown and what it has to offer. And then also on a personal level, just exploring things myself and learning what my colleagues have to offer me. So thank you. So I don't have any direct questions right now.
Well, thank you for sharing that journey with us. Marion, do you have, you're an osteopath, and so maybe you have a bit of a different perspective. Massage therapy is your background before osteopathy. So do you have any questions or thoughts just around broadening your scope or your role as a clinician?
I think one of the issues that lately I feel is coming up a lot for me is when I have a patient come in and they were told something by another practitioner that doesn't really necessarily resonate with what I think is going on, how to sort of navigate through. You don't want to obviously put the other practitioner down or make it seem as if they were told something wrong, because then that'll just cause a lot more confusion and stress for them. But there are certain things that come in my practice that I'm just kind of like, oh, I totally don't think that this is what's going on. And just kind of how to approach that, really. Or do you not? And you just kind of do your thing and, you know, build the trust with that client and then, you know, take it from there.
Yeah, I guess where even with us thinking of kind of like evolving our scope, like as physios, and coming out of this like fixer mentality and really trying to kind of connect the dots and take this more of a systems approach. I guess because I really have shifted into sort of that more evolved way of doing my practice, but that doesn't mean I've thrown away my other skills. I mean, anytime I have someone in my room at the womb, I'm using all my sort of well-conditioned hands-on skills, right? But I would say I bump against the same type of thing when I have a client communicating that another practitioner they were seeing is speaking to them from that fixer mindset. You know, I'm putting your pelvis back together, or I'm right. And so I very much will handle it just by, again, coming back to the data and the principles. And, you know, I'll say, yeah, well, certainly what we understand now, you know, following the science, is that it has more to do with when I have my hands on you, I'm in your tissues, and really I'm having almost a conversation with your brain, and your brain's kind of deciding. So it's not to say it's not doing anything useful. It is, but it's not doing what we used to think it was doing. So I will actually try to gently sort of resolve gaps in understanding. That having been said, I think at the end of the day, it really is difficult for someone if they're hearing one perspective and another perspective.
Yeah.
And I'm generally trying to empower someone to really kind of cultivate that confidence, so they're moving on in kind of a different way of thinking and being anyway. So really trying to have them not really reliant on practitioners anyways. That I do think that that's tricky. And I will try to acknowledge, at the end of the day, it's probably not going to serve you well to be working with different people who are all trying to help you, but they're coming at it from a non-unified perspective. That's like a team that is never going to achieve that common goal, right? So I will usually be very honest about that. I think over the years I've gotten a little bit better at it, but it can certainly be a tough situation. What do other people think about that?
So I think that it's always tricky, because as a physio and one who treats a great deal of persistent pain, I on a daily basis hear the stories that I know are not grounded in the science that we have now. And it's, so I spend time when I hear that, I just start getting curious, and I spend some time and I ask them, well, what do you think about that? And how long have you been thinking that? And what does that mean? And how has that helped you move forward? And most of the time, what I hear to that last question is, how has that helped you move forward? Well, it hasn't, because the story that I'll hear is one like Sinead hears, I lay on the table, they do manual therapy, and I'm all back in line. And then I get up and I walk across the room and I'm all back out of line. And I said, well, do you really think it's an alignment problem? I'm just at, kind of wanting to get out of their head what they're thinking is going on, and then it kind of opens the door for like, well, what if it was, something made you look and feel like you're out of line because it's a story that you have, but it really was coming from some other reasons. That, can we explore those a little bit? Because it might help you think a little bit differently about how you want to proceed forward, or what you want to, or what might be more helpful for you, because this has proved to be something that you think you need to do, but it hasn't really gotten you anywhere. And so that's kind of, where I go with it a little bit, is just really trying to get more of their story about it. Like, tell me more, really dig it out of them. And usually they come to the conclusion that whatever it is they're asking you about, they may be telling you something, but what they're really doing is they're saying, do you believe this?
Yeah, and I definitely think they sometimes will come, and like in one incident, there was, one client who is constantly getting UTIs, like I think like 5 UTIs in the span of like a 7-month period, and then finally decided between osteo and pelvic physio to sort of look at it from a different perspective. And, we just saw her last week, and I think she's been 5 months, no UTIs after doing the combination of the treatments. But, her frustration is that, well, why did they keep giving me antibiotics? And, I can't answer that question, but
I would often say at that point, Marion, that their family doctor, whoever was prescribing the antibiotics, was actually doing the best medicine that knew how, given the skill set and the information that they had at the time. And all have a responsibility to sort of really keep up to date. But that doesn't mean, Sinead's point to, sort of family physicians training to do even internal exams to assess pelvic floor strength and do a pelvic health component. We've had level 1 evidence for 12, 13 years now that actually internal palpation to teach a pelvic floor contraction, which physicians can easily do, is the number 1 choice for treating incontinence. And yet, it takes a long time to change practice. So it's not that they're bad practitioners, it's just that they're working within their skill set at that moment and at that time. And I think so many of us, and I think, treat in silos, right? We have our specialty, we have our organ that we look at, and we can't think beyond that because we're not trained to look beyond that. So again, I kind of cut other clinicians a bit of a break, because I think everyone does do the best that they can do. I think it's Maya Angelou who said, do the best that you can. And when you know better, do better.
Do better. Yeah.
And I always I do the best that you can today. I shudder when I look back and think of how I treated 20 years ago. I strengthened everyone's pelvic floor from 2000 to 2006. Everyone got Kegels, but that's the best I knew at that point, right? But I know better, I need to do better. Now that I know better that central pain mechanisms are really the driver of the majority of sort of protective mechanisms in the pelvic floor, I've got to change my trigger point language. I've got to do things differently. So when you know better, do better. Right?
Thank you.
And if I could just elaborate on that. Oh, sorry,
Mhm.
Susan.
Oh, no, go ahead,
A
Nicole.
little bit. I agree with everything that everyone said, and and it really depends on the present, like the person in front of you and how they're presenting and what they're speaking and their language, and it really kind of dictates how you respond to that, which is not very helpful for you. But you kind of sometimes stumble along, but sometimes a door opens up and you kind of and so one of the other things that sometimes I do is like if they'll say, well, I've done this, or this is what this practitioner has told me, and we've done this, and I'll say, okay, well, great. So, now what we're going to do is we're going to expand on that and take you further, or try slightly different, maybe there's a bit of a missing piece to this, and this is why it's not, it hasn't served you fully or as well as you'd like it to, because we're just missing a little bit of a piece to the puzzle. And why don't we explore this and see if this is going to, so elaborating a little bit along the lines of what Susan was saying too.
Yeah, diffusing frustration is always tricky.
Yeah.
That's what it is when they say, why didn't somebody, like, people always want to know, why didn't 10 years ago somebody do this? And it's like, well, we can't go back in time and change what happened 10 years ago, but
Yeah.
now we can, and I give them this space to blow that off, to get it out, say it. It's something that you need to say, and I'll just, with empathy, you can kind of just give them that, boy, I know that's frustrating, isn't it? And it's so great that you're doing better now, though.
Yeah, for sure.
And, like, wow, I honor your journey, what a journey you've been on, but wow, it sounds like we're heading in the right direction now. Yes? No?
Mhm.
And then let them keep going. So that's fabulous. Such great questions tonight.
Lovely discussion. Sinead, do you have one word of one little piece of advice of wisdom for us, or for people who are listening to this, around what the next step may be for the profession? Where do you see this going?
Yeah, I guess I would say that I do think that if we can almost follow a little bit of a path of what we've done with kind of pain neuroscience education, which now has morphed to showing us that it's much more effective when it's almost pain neuroscience counseling, and it needs to be very much connecting the dots to the person's story. If we can kind of follow that along, because to do that well, we need to know the physiology well. To do that well, we need to kind of switch into this a little bit of a counseling mode. We can use that as a template. I think it's easy to then follow along with the lifestyle intervention bit. But I think we do see that as a profession, we haven't even really adopted being able to enact that first part properly. So I do think we have to look a little bit more about, really looking at what are the needs of people sort of in the 21st century. And it's these kind of lifestyle conditions, it's pain that we understand is centrally mediated and not peripherally mediated. So I do think we really have to look at, where did we come from? And we came from serving population needs after the war. And that's why that skill set made sense at the time, but we know differently now. We have different priorities now, and we are the largest non-pharmacological healthcare group in the world, right? So we are the largest conservative care lifestyle interventions, pain neuroscience counseling. It should be ours. So hopefully that's like a motivator that we can all kind of move forward.
Super. Well, thank you for your leadership in this space. Thank you for sharing your thoughts and wisdom with us over the last 2 sessions. We really, really appreciate it. And we really appreciate Nicole and Janice and Marion coming on and sharing your questions and stories with us. And until next time, thanks everyone.
Thank you, everybody.
Everybody.
Have a great night, everyone.